Welcome to Why Words Matter through a general surgical lens. The key objectives for today's session are to develop an understanding of the role that documentation plays in determining patient severity of illness, risk of mortality, and how this impacts physician quality scores. You will also be able to understand definition changes and key terminology changes in ICD-10-CM and ICD-10-PCS. And you will understand the concepts of linking conditions and manifestations and greater specificity documentation for a more accurate depiction of patient status. First, we're going to spend some time talking about the importance of documentation and basics of ICD-10 CM-PCS. What was once a tool for communication between provider and clinicians is now the primary data source to determine quality of patient care. Our audience for our documentation has really significantly increased. It's increased to include governmental agencies, insurance companies, not to mention the patients and other caregivers who now have access to their electronic medical records. So it's very important that the clinical documentation is very accurate in depicting the disease processes and procedures that you will be performing on your patients. The changing healthcare landscape and new payment models are driving increased scrutiny of clinical documentation in order to validate accuracy, quality, and value of the care being provided. And as you can see by this slide, there are a number of forces that are in play currently, such as value-based purchasing penalties, obviously the transition to ICD-10, CM-PCS, payment reforms, and the fact that we are dealing with a much sicker population on the inpatient side. There is increased transparency for all patients, and you now have a virtual reputation that can and will be accessed on public websites. This reputation is created from data that is driven from your clinical documentation. Patients are now able to access your virtual reputation on sites such as physiciancompare.gov, healthgrades.com, and even through their individual insurance provider websites. There are a couple of concepts that are very important for you to understand moving forward in terms of how your documentation really can impact things like severity of illness and risk of mortality. The metrics of severity of illness and risk of mortality are used to measure patient acuity and therefore drive expected patient length of stay and mortality rate. The clinical documentation drives the assignment of these levels. These levels are determined based on a number of factors including primary and secondary diagnoses, comorbidities, demographics, patient history, treatment and procedures delivered, and other patient-specific information. As you can see by this graph, documentation really does impact the quality dial. This slide represents the impact that improved clinical documentation can have on observed versus expected mortality rates. The OE ratio, observed mortality rate over expected mortality rate, is an important metric in healthcare. You can see that prior to this particular facility beginning its documentation improvement initiative, the expected mortality rate of its patients was really being represented very low, and it had what appeared to be an overly high observed mortality rate. But as the clinical documentation improved and the severity of illness and risk of mortality of the patients were actually captured more accurately, you can see now that the expected mortality did outstrip the observed mortality and really started to depict the good quality of care that this hospital was providing. So why should we go from ICD-9 to ICD-10 CM-PCS? What really is the benefit? Really, it provides much better accurate detail and a more accurate depiction of patient severity. Keep in mind that in the ICD-9 system, we are really trying to find a code that matches your documentation. That's not always necessary, and sometimes things are coded just because that's the closest fit that we have. In ICD-10, however, the codes are built to reflect exactly what your documentation is saying, so we are able to much more accurately depict what's going on with your patient. This will help to improve management of patient care. It will also help in terms of obtaining robust clinical data that can be used to make a lot of decisions, such as accurate payment for new procedures, capture morbidity and mortality data, the value of new procedures and maybe even addressing global disease emergencies. It also will be helpful to have much more accurate data in terms of looking for miscoded or improper claims or even fraud and abuse monitoring. So why so many new codes? The main difference between ICD-9-CM and ICD-10-CM-PCS outside of the structural changes is really the specificity of the code. ICD-10-CM-PCS code specifies several components not found in ICD-9, such as causal agent, type, laterality, approach, episode of care, and route operation. In this diagram, you can see the number of procedure codes far outstrips the number of diagnosis codes in ICD-10 because of the ability to capture all of those elements that were mentioned earlier. Here is what an ICD-10 diagnosis code looks like, and you can see it's broken down into 3 sections, and it has some key documentation concepts. First of all, documenting specific anatomic location, the type of disease process, primary, secondary, acuity, degree, mild, moderate, or severe, episode of care, which is a new concept in ICD-10 that we'll spend a little time on later. Laterality is a huge new area that we're able now to capture with much more specificity. And then there are some other concepts that are related to other subspecialties. The ICD-10 PCS code now takes on a new different look with 7 different sections being able to be captured. All of these sections are required for the particular procedure code to be built accurately. And you can see that the physician documentation that's required is the type and intent of procedure, what specific anatomic sites are treated, what the approach was, any specific type of device that was used, and any expected or unexpected events in the perioperative period, and any diagnosis that would support the inpatient medical necessity for this procedure. So now we're going to talk in general about some key concepts to capture in your documentation. ICD-10 has an awful lot of changes, particularly in the surgical subspecialties, but really there are just several concepts that really are driving the majority of changes. And as you can see by this slide, laterality by far and away is the greatest change that now is driving some of the new addition of codes. Documenting laterality is usually not something that is missed often by physicians. However, the most common thing that we see around laterality is that it is constantly, it could be inconsistent throughout the record. So laterality becomes very important. Complications, acuity, infection sites, type of infection, causal agent, these are all concepts that if you keep in mind with your documentation moving forward, you will be very well prepared for ICD-10 diagnosis code or ICD-10-CM. Similar concept happens in terms of ICD-10 PCS or the procedural coding set. And you can see here that the approach is probably by far and away the largest new concept that we can capture. Route operation, the exact type of operation that you're doing, laterality, type of device, type of imaging, excision site, all of these are concepts that for the most part you are already capturing in your very detailed operative reports, but now in ICD-10, CM, and PCS we have the ability to actually identify these within the code set. In some instances, there's conflicting, incomplete, or ambiguous documentation in the medical record, and this would really generate the need for additional documentation or clarification, or what we sometimes refer to as a query. So when the record fails to meet one or more of the following criteria listed on this slide, a query or a need for clarification will be generated. Obviously, with the advent of the electronic medical record, legibility will not be an issue for much longer. However, it certainly can still be with the hybrid records. Things like completeness, clarity, consistency, and precision in the medical record are very important. So conflicting documentation between 2 or more treating providers needs to be clarified. Making sure that clinical reports and clinical conditions are documented as specifically as possible. Making sure that lab results, abnormal test results, and their clinical significance or lack thereof is also clearly documented in the medical record. Remember, documenting signs and symptoms and test results really should be linked to a related diagnosis if a diagnosis is known. Linking signs and symptoms to diagnoses will increase severity of illness and risk of mortality in the inpatient setting. Remember, in the inpatient setting, terms like probable, likely, or suspected are also acceptable on the inpatient record if you are monitoring and treating as if that condition existed. However, keep in mind that in the outpatient or ambulatory setting, documentation regarding patient condition is only allowed to the highest level known. So in a lot of instances, the only thing that you do know for sure is the symptom because you are in the process of trying to identify the diagnosis. So in the outpatient setting, documentation of symptoms is absolutely appropriate. Remember that abnormal findings, labs, x-rays, path reports, and other diagnostic tests cannot be coded and reported unless the physician documents the clinical significance in the progress note and discharge summary. A good example of this is a laboratory finding of a decreased hemoglobin and hematocrit. The coder cannot assign a diagnosis of anemia to that abnormal laboratory finding unless the physician actually links that diagnosis with the finding and states the diagnosis of anemia in his or her progress note. Remember, documenting all conditions in the progress note and discharge summary is the responsibility of the attending physician, and also it is the responsibility of the attending physician to resolve all conflicting documentation within the medical record and make sure that the record is clear and concise and accurate at the time of the discharge summary. It's also important to remember that linking conditions is critical to capturing patient severity. There's a significant increase in the number of what we call combination codes available in ICD-10 code set. These codes help capture the highest level of complexity and acuity in publicly reported data. So linking clinically relevant conditions where appropriate is the key takeaway that physicians need to incorporate in their documentation today. Remember, coders cannot assume such clinical relationships. And in the blue box that you see on your screen, you can see the linkage of some diagnoses that you might see frequently. So acute appendicitis with perforation, or acute blood loss anemia due to esophageal ulcer with bleeding. Using terms like due to and with will help make it clear to the coding professionals that you are linking these disease processes together. Now what we're going to spend some time on is going through some examples of general surgery procedures that may be impacted in ICD-10 PCS and pointing out some things that will be helpful as you try to improve your documentation in order to document more accurately for ICD-10 PCS. There are some procedures and diagnoses that we're going to cover today. Some of them will be covered very briefly. Others we're going to spend a little bit more time on. What are the requirements for documenting root operations? If you remember back to that slide that showed the 7-digit PCS code, one of the digits was root operation. And really, it's not important that the physician specifically calls something a root operation, but it's important that the physicians document the specific type or give specific and clear documentation so the coders can assign the appropriate root operation. The root operation really needs to identify what part was removed when removing an object, whether it was a solid matter, kidney, gallstone, or bullet, or identifying the mechanism that you're using, stripping, cutting, or destruction. So those are important things to remember, and honestly, in most operative reports that I've looked at, all of those things are documented very clearly if there's a good detailed operative report within the medical record. Keep in mind that coders will read the operative reports in order to pull out all of those elements of the procedure code that they need. There's also a requirement for documenting body part in ICD-10 PCS, and now we have the ability to capture much more specific areas of body parts. So remember to document specific anatomical site of the body system on which the procedure is performed, and then identify any other smaller areas such as nerves, arteries, veins, portion of the spinal cord that is also being included in the procedure, and make sure to include laterality if it is appropriate. There's also some requirements for documenting the approach in ICD-10, and approach is another one of the digits in the ICD-10 PCS code. The access location, the method of approach, whether it's open, percutaneous, or endoscopic, and what type of instrumentation was used. There's also a digit that helps to capture the type of devices. There are 4 general types of devices that are captured in ICD-10: grafts and prostheses, implants, simple or mechanical appliances, and electronic appliances. You can see in this particular slide that there is no device in this patient, but you can see very clearly the root operation was a bypass, the approach was percutaneous, endoscopic, and the qualifier really is an option that allows us to be much more specific about areas that we are operating on. So you can see the level of specificity that now the ICD-10 PCS codes will allow us to capture. Here's another example of a cholecystectomy with an open approach diagnostic. Here's what a code would look like with the resection of the rectum, open approach. And you can see here again, the body part options are very, very specific. And the more specific you can describe that, and you typically do in your operative reports, the more specific the coders can be in assigning the appropriate digit for that code. Here's what a code for an appendectomy would look like. And again, we're highlighting the root operation and the approach that was taken. An important concept in surgery is the dealing of pain in some patients, both surgical and non-surgical patients. There are some new documentation requirements around pain in ICD-10. First, the pain should be clarified whether it's acute or chronic. And if the patient is being admitted for the treatment of pain, that should be very clear within your documentation. Or if the patient is being admitted for an underlying condition that is causing the pain. So if the main treatment for the admission is surrounding the pain, that really is your admitting diagnosis. Make sure that if you can, you link the pain to the type of condition, so chronic pain due to. And again, we're utilizing the terms of due to or with to link those conditions together. And then make sure that you document whether or not there's some modality that is being used to help treat the patient, such as an intrathecal pump or a spinal neurostimulator. Here's what a code for pain would look like in ICD-10. So let's now shift gears and talk about best practices for procedural notes. Typically, this is already what you do in your procedural notes, but I just want to take some time to touch on a few areas within the procedure note. I think it's important to remember to document the intended procedure and the procedure that was actually performed. If they're different, it is important that there is a document that explains the reason for why the procedure changed. And that may very well be something that you were unaware of until you actually started the intended procedure. Make sure that if you're utilizing or leaving behind any device, that that device is clearly identified. If there are any instances where the procedure was made difficult or longer, maybe because of extensive adhesions that caused some difficulty, that's also very important to include in your operative report. And then also document any unusual findings. Make sure that any complications that occurred during the procedure are clearly documented as either accidental or a true complication of the procedure, or maybe even due to some underlying disease or condition that the patient may have had prior to going into the operating room. ICD-10-CM coding terminology is going to change to more accurately identify when complications occur. ICD-10-CM really has now started utilizing the term post-procedural or post-surgical to reflect anything that occurs in the post-operative period. It's very important that conditions occurring in the postoperative period are clarified as either expected post-procedural or post-surgical condition, such as an ileus after abdominal surgery, or an unexpected post-procedural or post-surgical condition unrelated to the surgical procedure, an unexpected post-procedural condition related to the patient's underlying comorbidities. For example, maybe the patient has chronic obstructive pulmonary disease and has quite a difficult time being extubated. Or an unexpected post-procedural condition that is related to the surgical care, a true complication of the care. Documentation of procedural complications really has some particular concepts. Timing, whether it was intraoperative, postoperative, or late effect. The procedure, what type of procedure was done. Are there any things associated with it? Was it accidental? Was it due to drugs? Was it an adverse effect? And now we're touching on a new concept, encounter, initial subsequent sequela. And we're going to spend a little bit of time on that a little further into the presentation. When documentation within the record is unclear, the physician will be queried and asked for clarification by the coding professional or by your clinical documentation improvement specialist. Remember that outpatient procedures will still remain in the CPT coding system. It is only the ICD-10 PCS codes will be used only on inpatient procedures. This is an important concept. Inpatient procedures will be coded with ICD-10 PCS coding terminology, but outpatient procedures will remain with the CPT HCPCS code set. Now we want to take some time and shift gears and talk a little bit about comorbid conditions that may complicate surgical patients. And for the most part, if the surgical patient does have some of these medical conditions, there's typically consultants that are assisting the surgeon, and those consultants can also be very instrumental at helping you capture the severity of illness in your surgical patient. So within the circulatory system, remember that documenting hypotension, low blood pressure is not equivalent to stating that the patient has shock. If the patient does have shock, you should document that very clearly. Make sure that you include laterality or any other associated comorbidities, and look for changes in home medications, including or that might indicate acute on chronic conditions. Within the respiratory system, it's a very important concept to remember that documenting acute respiratory distress is not the same as documenting acute respiratory failure. It's important to get credit for severity of illness and risk of mortality in patients with respiratory problems. So make sure that if acute respiratory failure is present on your clinical judgment or your consultant's clinical judgment, it is clearly indicated. And if it's an acute episode on top of a chronic disease process, make sure that that is indicated as well. Here's some respiratory complications of surgical procedures. And again, you can see that we'd like to see you use terms due to or with. You can see here that pulmonary manifestations were due to radiation is a way to document things. Remember that complications really have no time limit. So any surgical procedure could really result in a respiratory complication, whether it is due to the surgical procedure itself or an underlying medical condition that the patient had prior to going to the operating room. The key takeaway here is to be as specific about the details of the complication as possible. There are complications surrounding tracheostomy, and again, I think this is where the time limit factor really comes into play. The complications really have no time limits, particularly when it comes to tracheostomies. So make sure that you're documenting that this is a complication of the tracheostomy and the type of complication that you're dealing with. In respiratory conditions that require mechanical ventilation, there is something new within ICD-10 that we're able to capture that we cannot particularly capture right now in ICD-9, and that is a more specific delineation of duration. This is not something that you as the physician would have to document specifically counting the hours, but most importantly, the date and time of intubation as well as the date and time of extubation are the important key things that you need to remember to have documented in your record. If those dates and times are clear in the medical record, your coding professionals will then be able to identify the appropriate time frame to code these ventilator patients. We're going to talk now a little bit about some digestive system concepts. Remember things like symptoms of hematemesis, melena, GI bleed. They're more symptomatology and they're not very specific. We recommend documenting the most specific diagnoses that you are aware of at the time by utilizing terms like acuity, link it to anemia if anemia happens to be present, or link that condition to any underlying cause. Remember also, if the patient has any alcohol or tobacco use or history, that should be included in your documentation somewhere within the medical record as well. Here's just some more concepts around specific digestive system diagnoses. And again, we're going back to that slide. If you remember the slide with the bubbles on it in terms of diagnostic codes, things like site, laterality, complications, locations, associated conditions. It's not so much important that you remember specifically the words on this slide as much as you remember those larger concepts that you can actually start documenting in your medical records today. Site, laterality, complications, location, acuity, any associated condition. Those are things that you will see are common themes that will run through the remainder of the slides that we'll be going through. Here again, in terms of documenting around enteritis, we're talking about documenting the site, the type, the laterality, and also document complications of rectal bleeding or obstruction, fistula, or abscess if there are present. And remember to include the use of alcohol or tobacco in your documentation. If that information already exists in your history of present illness or in your history and physical of that patient, it's not necessary to repeat that consistently throughout the record. As long as it's there and obvious to the coding professionals, it will be captured accurately. Here's some more GI conditions, and you can see again, if you look at the right-hand side of the screen, we're really focusing on those larger concepts: acute or chronic, with or without hemorrhage, the site, any complications, the degree if appropriate, and the location. Again, always document acuity, acute on chronic or chronic, and whether or not obstruction is present. Here we're talking a little bit about diseases of the gallbladder, and once again we want to talk about things like identification of site and be very specific in terms of cystic duct, bile duct, and also remember to document any other conditions that might be present, such as adhesions, ulcers, and any other things that may be complicating diseases of the gallbladder. Remember that digestive complications and diseases can change severity of illness in a surgical patient. So it's important to identify the following diagnosis and whether they are complications or not. Sometimes ileus is an expected outcome of a surgical procedure, such as abdominal surgery, but in other instances it may be related to medication. So it's very clear that you include that clarity around your documentation. Keep in mind when documenting post-procedural complications, here's a couple of examples. So for example, if the patient has vomiting following surgery as a complication, it should be documented that way if it is considered excessive for the procedure and if it is due to any pain medication. Look for other post-procedural complications and document them appropriately. Things like obstruction, hepatorenal syndrome, or any ulcer development. We talked about the importance of documenting tobacco exposure in ICD-10, and this is a new focus within ICD-10 that will help us with the ability to identify diagnoses and procedures that are affected by the patient's use of tobacco. So it's very important to document the level of usage and the type of usage or exposure if it's known, whether it's current or past usage, whether it's dependence, whether it's in remission, whether it's secondhand smoke. All of those things are important to include in your documentation. We're still focusing on some of those chronic medical conditions that may complicate your surgical patients. And again, remember that your consultants can be key in helping you get the severity of illness and risk of mortality of your patients by clinically documenting these conditions accurately. It's very important in terms of diabetes to document any manifestations or complications and link any procedures from a diabetic-related problem back to the diabetes. Here's an example of utilizing the term diabetes with hyperglycemia, with ketoacidosis, or some other manifestations such as diabetic nephropathy or diabetic neuropathy. These are very, very important and will include a higher severity of illness and risk of mortality if you utilize that best practice documentation pattern. Pressure ulcers are very important, and it's also important to specify the stage, the laterality, and the site of an ulcer. As you can see now, in ICD-10, when it goes into effect, hopefully in October 1 of 15, there are a number of synonyms that will be used to identify pressure ulcers, and you can see those here on the right-hand side of your screen. Remember to document laterality, the site, the severity. Remember, it's very important to document the accurate stage of the ulcer. Is it current, new, or healing? And if there are any other underlying medical conditions or incidents that may have led to that pressure ulcer. Here's what a code for a pressure ulcer of the right buttock stage 4 would look like. Remember that excisional debridement is an important concept around ulcers, and that is a very important documentation concept to keep in mind. It's critical to specify whether a debridement is excisional or non-excisional. There are two types, and the definition of excisional debridement is cutting out or off, without replacement, a portion of the body part. A non-excisional, even a sharp debridement, could be pulling or stripping out all or a portion of a body part by the use of force. It's very important that the physician utilize the term excisional if that was done, also to include the type of instrument that was used, the location, most importantly, the depth of the removal of tissue, and the surface area, which is important for CPT coding. Here's what an excisional debridement code would look like. Burns are an important area in ICD-10 documentation as well, and it's important to document the type, the depth or degree, the extent or percentage, what agent caused the burn, the actual site, the laterality, and is this an initial, subsequent, or sequela encounter for that burn. So let's summarize some best practice teaching points for documentation. Remember that conflicting, incomplete, or ambiguous documentation will most certainly lead to a query. So it's very important that you minimize those queries and that interruption to your day-to-day practice by making sure that your medical record is always very complete and accurate. Documenting symptoms will also lead to a query if the coding professional or CDI specialist anticipates or expects that there is a known, suspected, or probable diagnosis that you might be monitoring or treating. Remember that medical conditions increase severity of illness and risk of mortality when related with other conditions. Remember to use the terms due to and with when applicable and appropriate. Physician documentation must specify if debridement is excisional or non-excisional. Remember that complications have no time limit. Remember the example around the tracheostomy. So if there are complications, it really should be documented as such. And then those 4 areas around documentation that occur in the post-operative period should be clarified. Coding terminology for key procedure types will change with an ICD-10 PCS, and understanding the definitions to better recognize codes in your daily practice is very important. At the end of this presentation, there is an appendix that will include the definitions of those various coding terminology changes within ICD-10. Remember to always specify the type of device used, capture the approach in your operative report as specifically as you can, and remember to clarify any conflicting, incomplete, or ambiguous documentation to avoid any CDI or coder clarifications. Remember, ICD-10-CM requires documentation of tobacco exposure, and that's usually included in your history and physical document. So we'll circle back to the major concepts driving the majority of changes in the ICD-10-CM diagnosis code set. And you can see here once again, laterality, complication, infection site, acuity are all very important concepts. If you can remember these concepts as you're going through your daily routine of documenting, you will hit most of the elements that will be required in ICD-10 diagnosis codes. The same is true for ICD-10 PCS or procedural code sets. If you can remember to document the approach, route operation, laterality, type of device, excision site, any type of imaging or contrast, focusing your documentation on these concepts will help make sure that you are able to provide the coding professionals with all of the documentation that they will need to code your procedure accurately. As I said before, the appendix does include a number of slides that will include definitions of some of the elements of the ICD-10 PCS code. Thank you for listening to Why Words Matter through a General Surgery Lens.